thank you very much for the invitation to speak today. I mean, David, if you could just tell me when I have like 5 minutes, because sometimes I go over under. Okay, super, thanks. So a little bit about myself. So I'm a computer scientist by training. I'm Greek, but I'm based in London, where the weather is different from Greece. And I'm interested in all sorts of like kind of ontological and health data science topics, particularly ontologies, which you'll see is kind of a common theme across a lot of my talks. So just to introduce what I'm going to be talking about today, I think it's safe to say that at the moment, the current paradigm of clinical care for a lot of diseases is a one-size-fits-all sort of way of treating diseases. So you have patients that have the same disease, but are heterogeneous in terms of biological sort of manifestations or phenotypic manifestations. They all get the same treatment, and that treatment may have a positive effect in some patients, may not work in other patients, and may have adverse events in other patients. And the reality is that where we want to be is this notion of personalized medicine, where we understand how individuals are different, even though they have the same disease, how their phenotypic details are different, and we have a personalized approach to care. So personalized, or it's also called precision medicine sometimes, basically means getting the right treatment to the right individual at the right time. And so all the individuals benefit from a treatment, and you minimize the number of patients that have negative effects or adverse reactions. How does that look in practice? So, traditionally people cite pharmacogenomics and sort of CYP29 sort of catalyst as the example. This is one of my favorite examples in colorectal cancer. On the left-hand side is where colorectal cancer treatment was sort of around a decade ago. So they had identified a single gene that was targeted by a single medicine, and that was given to all individuals with the effects that we discussed before. And ideally, you want to be on the right-hand side. So new subtypes of cancer driven by transcriptomic profiles, immunological profiles, and other differences in sort of genomics have been identified. These subtypes drove the creation of novel biomarkers to identify more accurate markers of disease progression. And as a result, more treatments were created that target individuals that match any of these particular subtypes. So this is sort of kind of the poster child in my mind of how personalized medicine should look like. So why is this happening, and why are we in this situation? I would argue it's because a lot of the decisions that are currently taken in clinical care today are based on really small sample sizes, on very limited studies, and on very tiny populations. The traditional way of doing research in this context is what's called a consented research study, also known as a cohort study. So what happens is you get funding, you recruit individuals, you invite them to an assessment center, you take all sorts of measurements. Sometimes you might send them by post things. You then follow them up. So you wait 15 years, you invite them again, you send them an online questionnaire, and this goes on and on and on. And on the right is a sort of a screenshot of one of the questionnaires on a really famous study here in the UK that's called the Whitehall 2 study. It was on male civil servants trying to identify if stress at work is associated with adverse health events. So this is just an example of the questionnaire that they were given during that wave. A more contemporary example, so this was, I think, sort of in the 70s. So this is like really old study, kind of like in one of the first large-scale epidemiology studies. A more contemporary example is UK Biobank, is one of the largest studies in the world. So they recruited individuals in the UK, and you can see where the assessment centers were. And they got really, really rich phenotypic and genotypic data. So everybody has NGS. They have proteomics, lipidomics, et cetera, imaging scans, all sorts of things for 500,000 individuals. So this is a very, very highly phenotyped cohort. The challenge is that, for rare diseases, it's quite limited. And also, people have done a lot of research and realized that actually it's not representative of the UK population. So people that take part of these studies traditionally are more affluent and they're in better health. So you miss a proportion of the population. So this essentially is kind of selection bias. There are other challenges with how these research studies are run. At the moment, funding is a big one. UK Biobank costs sort of, I think, £100 million to set up, and it's been going for, I think, 15 years or so. These are very, very expensive, especially in the current funding climate to do. They require a lot of resources. They're very time consuming. Yeah, there's a selection bias. There's also recall and reporting bias. You ask participants, and if you look at the questionnaires, they sort of have very generic kind of questions of, has your doctor ever told you suffer from diabetes, down to very, very specific, how many grams of brown rice did you have on average per week last year? So the people, and how you remember this information and how you record it is kind of very, very variable. So you're very limited in scalability in terms of diseases and population. So the question is, are there any existing data that are collected as part of healthcare that we can use for research? Use for research, not to replace research cohort studies, but to enhance them or to enable sort of complementary research to happen. So it turns out that when we interact with a healthcare system, we generate a lot of data and a lot of metadata. So in the UK, we have what's called the NHS. It's a national healthcare system. It's free at the point of care. So it's different from other countries. So in the UK, everybody's registered with a primary care physician, a primary care doctor. It's called the GP. So your gateway to healthcare is through that GP. Obviously, if there's an accident or an emergency, you can go directly to hospital. So everybody's registered with a GP, and you visit your GP and you get a lot of data points. They measure your blood pressure. If you're above 40, they sort of measure your heart rate. They take sort of a glucose measurement. They might diagnose you with something. You might get a prescription or two. Equally, when you get admitted to hospital, an outpatient or inpatient, or you have a surgery, there's more diagnoses being recorded. So you can see and think of all of these little data points as kind of Lego bricks. So each Lego brick is a piece of clinically significant information. And all these Lego bricks constitute sort of someone's entire healthcare journey from birth to death. Especially if you're British and you're born in the UK, you get a unique identifier that just follows you throughout your lifetime. And all of this data is attached to that unique identifier. I'm not saying that it's connected, and that's part of the problem that I'll talk about before, but it lives in silos according to that NHS number. And all of this information is recorded in predominantly clinical ontologies. So a very, very popular one is SNOMED CT that's used in primary care here in the UK. DM+D is another one that's part of SNOMED that's used for drugs. Hospitals use ICD-10, and they also have a specific sort of OPCS4 that's called for procedures. So all of these are sort of ontologies that are used. And these ontologies vary by healthcare setting, healthcare system, etc. So I'm Greek. In Greece, you can walk directly into a hospital and say, I want to see an eye doctor today. You wait, you see someone, and you get a diagnosis in ICD-10, and the information doesn't flow. So it's very, very different in each country. And this is like a really, really good, actually, editorial written by a guy called George Ripsack that basically said that the data that are collected as part of healthcare are not collected for research. So the primary reason for collecting data for healthcare collecting this data is for treating the individual and handing over between sort of wards or healthcare settings. It's not for research. It has a lot of feedback loops, and there's a lot of incentives and monetary incentives, especially in the US, for example, with sort of the insurance companies and how sort of costing there works. And there's a lot of ways of how, what gets recorded eventually in the record is an indirect picture of what the doctor or the healthcare professional is seeing in front of them. And this kind of process is skewed by all sorts of different sort of processes. So working with electronic healthcare records is super, super exciting. And, I've been doing it for many, many years now, but it's also very, very kind of challenging. And I'll show you some of these challenges. To use the Lego analogy a bit more, imagine it's your birthday, the delivery guy comes, you've ordered the Millennium Falcon, which is a sort of 7,000 pieces of Lego. You open the box, all the bags are open, you just get 7,000 pieces, and also there's a manual that's missing. And that's kind of a bit how you work with electronic healthcare records. We get these huge data sets that are basically very, very long data sets of sort of patient building blocks. And we need to recreate these building blocks to do research. The process of going from raw EHR data, which are like the raw Lego bricks, to something that you can curate and analyze in order to sort of answer an important question is called phenotyping. Phenotyping is sort of a term that's kind of borrowed / cannibalized by genetic research. If the genotype is the genetic marker of an individual, a phenotype is anything that's an observable or measurable characteristic. In electronic healthcare records, that means anything that we might want to extract from this complex sort of health data then we can use. It could be a diagnosis, a prescription, a blood pressure measurement, anything that might be sort of interesting. Phenotyping works sort of predominantly in two main ways. You can have algorithms that are what I call shallow complexity. So these are deterministic algorithms that no matter how many times you run them, they will always output the same result. So this is an algorithm that we created to develop, well, actually it says heart attack, but actually it's a cardiac arrhythmia, to identify patients that have a cardiac arrhythmia. It looks at the records, it combines them, there's some logic. No matter how many times you run this on the same data, it will always output, does this person have cardiac arrhythmia, yes or no? It doesn't actually have any sort of probabilistic kind of meaning. And then more recently, there's what I call deep complexity algorithms that look at more complicated sort of patterns of recurrent events. If you want to have the second heart attack someone might have had, or cancer remission, or look at subtypes of disease, especially with sort of imaging related. And they use more machine learning AI approaches. And a very popular one that I think is very, very cool is using non-negative matrix factorization that gives you sort of these vectors of disease that gives you a probability. This, the probability of someone having had a heart attack based on their available data. So they're very, very powerful for identifying subtypes of disease, but also allowing you to play with the thresholds of sensitivity and specificity. So that's kind of the basics of phenotyping. So this whole area, I think it's safe to say that was pioneered by a network of hospitals in the US, a research network of hospitals in the US that's called the eMERGE network. So there are roughly 10, the first phase was roughly 10 sites, and they recruited 100,000 individuals. And everybody who was admitted in these hospitals was genotyped. So they took blood samples and they genotyped, and they made available the data for research within this network. And what eMERGE did is really, really cool, because they had, for the first time ever, a centralized repository of phenotyping algorithms that they distributed across each center. So they developed the algorithm to identify patients with type 2 diabetes. They developed it centrally. They distributed it to the network. Every hospital ran it, and then they returned back positive predictive value. So they validated it in a distributed way. And then they also run GWAS studies on top of that and other cool things. So a method that they really sort of pioneered was called the phenome-wide association study. So if you're not familiar, a genome-wide association study is looking at a particular phenotype, and you look at the associations of all genetic variants, like single nucleotide polymorphism, SNPs, with that phenotype, and you get an output that's what's called a Manhattan plot. Each of these bars is a chromosome, and sort of the y-axis is sort of the p-value of the association. So you can find out which SNPs are associated with an increased risk of having a disease or a particular phenotype or not. So what they did is called the phenome-wide association study. So they kind of flipped that whole notion in inversely. So in a phenome-wide association study, you can look at all individual phenotypes, not just a single phenotype, and all available SNPs. And you get, again, these sort of associations that are plotted as a Manhattan plot again. But in contrast with the GWAS study, these are no longer chromosomes, but these are organ systems. So these are based on this classification that's called ICD-10. So the first one is sort of the purple one is infection. The second one is cancer. The yellow one is circulatory disease. And you can see for all the SNPs in your sort of array, what are the associations between all diseases. And this is only possible when you have electronic healthcare records. So traditionally, these studies are done in selected populations. It could be a trial population or sort of some sort of other phenotype population. And that's why you looked at only one disease, because you only had data on one disease. But once you start linking with electronic healthcare records, you have access to, more than 1,000 different diseases. And you can start looking at sort of associations across different SNPs and across different phenotypes, with the idea being that you can start identifying pleiotropic associations. You can start identify what are the SNPs that are related with more than one disease. And if these diseases are significantly different, can we infer something about a shared biological mechanism? So they did a really cool study initially looking at sort of only one center in Vanderbilt. So this was one of the first biobanks that sort of were created. They looked at only 5 SNPs, and they defined 700 different disease populations using electronic healthcare records, and they were able to replicate all of the previous associations that had been reported. Then they scaled that up. They looked at 13,000 individuals. They downloaded all the data from the GWAS catalog. So the GWAS catalog is a EMBL resource that curates the results from genome-wide association studies around the world, that kind of curates the SNP phenotype associations with the odds ratio and the p-value. And they were able to replicate kind of quite a lot of them when they were adequately powered. And that sort of validated, in a way, the ability to use EHR data and use clinical data for research. Because when you're able to replicate a signal that more carefully curated research data have identified previously, that's a good indication that the EHR data actually match kind of the case population that the previous studies had. And also another kind of thing that they really pioneered was this idea of using these associations for drug repurposing. So like I mentioned before, once you start identifying pleiotropic associations between variants and diseases, you can start looking at drug repurposing opportunities. So if you know that a particular disease, a particular SNP on a particular gene targets a particular disease, and you also know that there's a drug for that gene, and you identify another disease that is also kind of matching that biological pathway, maybe that's a good indication that you can use a drug and repurpose it if it's already licensed. And ustekinumab is like is a good example of that. That was originally for psoriasis, and then through phenome-wide association studies and genome-wide association studies, it now got relicensed or repurposed actually for Crohn's disease. So because they found that this was a sort of a monoclonal antibody that both Crohn's disease and psoriasis were associated with IL-12 and IL-23 receivers. So this is I added a lot of examples from genetic research because that's kind of, I guess, we're at this conference. But what I'm particularly excited about is that phenome-wide association studies actually are not only relevant for genetic data. So in a phenome-wide association study, the exposure is your genetic markup. Do you have this particular variation? Do you have this allele? Yes or no? But you can actually run phenome-wide association studies across all diseases for non-genetic exposures. So in this case, we run a phenome-wide association study. This is work from Mike Pietzner at Charité, looking at what are the diseases that people have when they got infected with COVID that could increase their risk of severe COVID. So there's 4 panels. I can't read it here or there. So there's 4 panels, each associated with a severe COVID outcome. I think one is respiratory failure, one is hospitalization. And what we saw is that for hospitalization due to COVID and severe respiratory failure, if you had previous respiratory disease, which are sort of all the diseases that are clustered there, that increased your risk. Whereas if you had mental health problems, or things like dementia or neurodegenerative disease, that increase your risk of long COVID. So this was, again, an agnostic approach. This was in 500,000 people in that data set, UK Biobank. This summarizes roughly 15 million healthcare events that were kind of grouped together and analyzed. And all of these different diseases popped up as signal associated with these kind of increased risk of COVID. So, this is a hypothesis generating study. But it was really reassuring to see that the diseases that we identified as being associated with an increased risk of severe COVID complications were also the diseases that the healthcare system in the UK had told, you should stay at home, you should not socialize because you have these diseases and you might be at an increased risk. So moving on the sort of the non-genetic kind of examples, another challenge with electronic health records is that no single source is complete. And each source captures data in a different way. And that kind of makes sense if you think about specific diseases. So if you have like diabetes or hypertension, that's probably always managed by your family doctor. So if you end up in hospital with diabetes, it means that something has gone really, really wrong. It might be amputation related or a shock or something like that. So each source captures a different sort of set of diseases, and no source is complete. This is work by Johan and Chris that we did during the pandemic, where we were able to access the EHR data for the entire country. So this is on 56 million patients. And we tried to map where and how COVID infections were recorded within the healthcare system. So this analysis took sort of roughly a year to clean the data and analyze it. And what we saw is this kind of really, really complicated Venn diagram that shows that each source, be it the death registry, the hospitalization, national testing data, and primary care data, contributes its own sort of set of unique COVID infection cases. And all of these vary by demographic factors, by comorbidities, and geographic distribution. So that was kind of the driving force of saying, integrating data from multiple sources is very, very important. And unless you use all these sources, you kind of miss a lot of cases. So we took that kind of notion and we applied it in a large collaboration with GSK. This is work that Anna leads at UCL to define a framework to define these diseases sort of in large biobanks and using multiple kind of EHR sources. And using that, you create the scaffolding that you then can apply to all sorts of problems. So, traditionally studies look at only a single source of information, like all the phenome-wide studies I showed you. They have only traditionally worked on hospital data because that's what's available in the US. But now we're able to span data that captures multiple data sources. And then, use that and enable others to do really, really cool research. So this is research by Julia at QMUL, looking at how proteomic signatures and proteomic data improve risk prediction. And again, only possible using electronic healthcare records. And she shows that in roughly 40,000 individuals, and I think 2.5 or 3,000 plasma proteins, in roughly 75 diseases that you see on the right-hand plot, including a very, very simple array of basic proteins, improves the prognostic sort of accuracy dramatically. And that's kind of like these research studies that you do when you want to make the justification for, getting this data for everybody in healthcare. So these are all sort of genetic informed examples. EHR have really, really changed the landscape, at least in the UK, in terms of just good old-fashioned clinical epidemiology and public health. This is research by Krishnan Bhaskaran at the London School of Hygiene, where they did something like, I think, very, very simple, but extremely elegant. They wanted to look at the association of body mass index and the risk of 22 cancers. So traditionally, you wouldn't be able to run a study like this because you would never have enough sample size to do all of these comparisons. Or, usually what people do is they sort of group cancers together, or they have one outcome called cancer. So using EHR data from I think it was like 5 million patients, they were able to show that BMI is quite heterogeneously associated with different across cancers. And they've done a similar analysis with smoking that shows, in some cancers, the association is almost null, and others, there's sort of a very, very sharp rise, and in others is kind of roughly kind of negative. And this heterogeneity is sort of what you really want to be able to capture, and that's why you want to use these large-scale resources. Rare diseases is also another area that kind of is of high interest, again, because we're able, for the first time ever, to look at the prevalence of rare diseases across large populations. So if you ever worked with Orphanet is sort of the gold standard resource for defining rare diseases, where rare can mean anything from let's say, infantile apnea to a disease that is only affecting 3 people in a Hasidic family in Brooklyn. So that kind of, they span the entire sort of range of rarity. And we showed that actually when you start using EHR data, you actually look at this mismatch between what Orphanet reports using literature and other studies and what actually is in the population. So, and on the right-hand side, interestingly, we identified hundreds of other diseases that are actually rare. They fall below the threshold that the UK government has set that are not reported in Orphanet. And again, it's only through these large-scale data resources you can identify this, because by definition, people that have really rare or really severe diseases would not be taking part in a research study. They might not be able to, or they might not be able to give consent. And you can take this paradigm and follow it through. You can define sort of how diseases manifest in humans across their life course. This is research done in New Zealand using UK data, looking at defining what diseases people are born with, what diseases people die with, and what diseases they develop over the life course in roughly 4 million individuals. And you start getting these really, really cool patterns. So you can see infections are very, very common in the first 10 years and the last and 80 to 90 years old, whereas mental health is more common in the 30s and things like that. But you can then look at sort of policy implications with this. You can also start looking at how multimorbidity, which is a huge public health problem at the moment because more people are living with more diseases, clusters around age, and identifying clusters of diseases that increase during age. and actually look at the patterns of diseases and how they occur, and what are the differences between multimorbidity in terms of age, sex, ethnicity, and in the general population. So these are all sort of really, really complex studies that unless you are able to have the resolution for them, it's really, really hard to undertake them. I mean, obviously, there are all the caveats that I mentioned before in terms of, the representative and who ends up in EHR data. So these are not, again, to replace sort of bespoke data collections, but they're just to complement them. And finally, another area that I'm really interested in is using machine learning to identify subtypes. So again, when you have large collections of disease patients, I remember that first slide that I showed where you have patients that have, let's say, type 2 diabetes, and you treat them as sort of the same. Well, we know that that's probably not accurate, and we can use machine learning to identify disease subtypes. So can we further stratify these patients that all have this disease based on clinical characteristics? And these clinical characteristics can be anything from simple biomarkers to sort of previous diagnoses or other things. So using machine learning, we were able to, AMI was able to find these different disease clusters and replicate them across different EHR data sources, and also then look at polygenic risk scores and identify that actually in some of these clusters, there was sort of a different signal across the sort of the different polygenic risk scores, kind of sort of pointing to the direction that, there are biological differences in these disease subtypes rather than an artifact of the data. And final example, common data models. Again, this is something that really exploded during the COVID pandemic. So for those who don't know, OMOP is one of the most common sort of widely used data models that's run by a consortium called Odyssey. So you might have heard of I2B2 and other things that are out there. OMOP, I think, is now kind of the dominant paradigm. And what OMOP does is it takes heterogeneous data and maps them to the OMOP common data model. And what that allows you is to develop one set of scripts that you can then execute across multiple data sources, provided that they've been converted to OMOP. So if anybody has ever taken part in a federated analysis, you'll realize that you use the term federated analysis, but you really mean is R scripts and Python by email with people running them, sending Excel sheets back with results. And it's really, really not kind of elegant. So what OMOP does is they've developed this tooling that they say, we'll map all the data to this standard. You have one set of tools that you then execute. All the centers execute that, and they return the results. Of course, it's a bit more complicated than that, but it enabled really, really large-scale studies to happen, such as this one on hydroxychloroquine, which was a drug used for malaria that a specific U.S. president was really, really keen on repurposing for COVID-19. Obviously, they showed that it actually doesn't have such a big positive effect and that it increases cardiovascular mortality quite a lot, especially when it's being combined with other drugs. So this study was rapidly done, i.e. in 9 months or so. It's 950 hydroxychloroquine users in 40 databases in 6 countries. The only way that this could have been executed was by use of a common data model. Like if you tried to do it the conventional way, you wouldn't be able to do it. And they were able to generate rapid evidence that then triggered the EMA and the FDA saying, hey, by the way, please don't use the anti-malaria drug for other purposes. So the caveat with OMOP and common data models is that, yes, they need EHR data, and also, all of these databases were already converted into OMOP. So the conversion takes a long time. It's really, really complicated. So it's all sorts of things going on. But once you do that, you're able to run these studies quite rapidly. And, they've done many, many really cool other OMOP studies. And this is sort of in the Danny Prieto Alhambra in Oxford. So final slide, I think, understanding and characterizing heterogeneity is kind of like the poster child of, I think in my mind, of precision medicine. I think electronic health records are a really, really good resource that can supplement and enhance traditional analytical approaches, but not replace them. So they're sort of the golden balance is somewhere in between. But I hope I've persuaded you that they have a lot of advantages in both genomic and non-genomic research, but also that they require a significant amount of work and across different skill sets to use. And just to say, this is sort of to acknowledge all the funding that has gone into all these examples that I mentioned. Thank you very much.
So thank you very much. Are there any questions? We have the two microphones.
So thank you very much. I have a question regarding the methods for what I think is really challenging with this data set is to take into account the time points and the temporality. And for instance, for the matrix factorization you mentioned, this is super hard when you have temporal data. So what is your catch on that?
Well, I think so. That's a good question. Temporarily, I guess it depends on your use case. In the majority of cases, what we're really interested in is identifying, does someone has a disease, yes or no, not when they had it. So if you're looking at more complicated use cases, and in this case, you can just work with the data as a bag of words type of thing, or look at a specific time point before, after. If you're looking at multiple events and you want recurrent, then yeah, you wouldn't be able to use non-negative matrix factorization. But previous examples of where I've used it, it performed quite well, even with temporal data. So one example, I mean, I didn't show it on heart failure when we were able to kind of use all the diagnosis and all the prescription data as a sort of as a matrix. That worked well when you did the filtering upstream. So we would say, take the heart failure diagnoses, exclude the last 6 months to remove any bias, and then use all the data before then. But it's the matrix itself doesn't have any temporal information. There have been really cool methods that are called tensor factorizations that take this into account. One is called, I think, LIME, that you create multiple sort of matrices as tensors that have snapshots of someone's health data over time, but I haven't personally used them.
More questions? I have, yeah.
Hello, thank you for the talk. My question is that in GWAS, it's quite common to remove family members to avoid confounding factors. I wonder if you've done the same in PWAS, or if you would if that's something that common in PWAS.
Yeah, it's in PWAS studies, the basic setup is usually the same. So that happens upstream, where you would remove you would deal with things like linkage disequilibrium or relatedness and things like that. So yeah, the basic things are the same for genetic studies. For non-genetic studies, you just include everything, but the caveat is that you have to acknowledge that some of the diagnoses that occur might actually be really, really similar, and you have to then look at how to interpret that data. Whereas in GWAS, you can then, your controls are basically what define that bias.
Thank you.
So I have curiosity. So you mentioned that in the UK you have all the data under the same patient identifier, etc. But to my understanding, the problem with the data is that they are in silos because they are in different data systems. Is this correct, or do they have any type of central repository or so?
Yeah, no. So they're all in different silos. So you're right. It's also the case in the majority of times that the primary care physician doesn't speak to the hospital and vice versa. So if I get admitted today into a hospital with a heart attack, if I don't die, the hospital will send a letter back to my family doctor saying, Spiros had a heart attack. We discharged him with this medication, check up on him in 3 months. That usually is a letter in many cases, and lands into practice, someone has to record it. There's no common EHR source. So when I first came to the UK sort of 25 years ago, there was a huge project called Connecting for Health for like millions and billions of pounds to do that. That failed. And now the new government announced that they will do it again and say we're now going to have a unified EHR data, but at the moment it's all very fragmented.
Yeah, well, it's a general trend. It's trying to centralize things. I have a curiosity with another word that you mentioned. I think it was the one made by the New Zealand with the data, and they studied the diseases along the age. So that one. So, but do they distinguish between men and women? Because we made a study on the prevalence of diseases across life between men and women, and it was, until the 50s, In the 50s, the men has more comorbidities.
Yeah, yeah.
But in the 50s, when the menopause, it changes the trend, but drastically changes. So
They did, yeah. So this is UK data. So there was a comparison between men and women, both for defining the diseases because of the comorbidities, and also when these comparisons were done. So this is comorbidity in women and men, and women and girls and boys and men for asthma. And what it shows is that the asthma between the two sexes is associated with different comorbidities. So, for example, in women, it's associated with inflammatory bowel syndrome, whereas in men, it doesn't. It also shows that even for when diseases are the same, like acne or dermatitis, the magnitude of association is different as well. And then we also did that across age groups, and we showed that, like, bipolar disorder, for example, had different disease associations in younger adults compared to older adults. So I think it is important to stratify these analyses by all of these different factors because they really influence, but then interpreting them it becomes really, really hard, because then you have sort of, you get kind of hundreds of result sets. That's really, really difficult to sort of visualize.
right. Do you have information on the socioeconomical level? Because in our experience, this is extremely important. So if you are poor, everything goes worst, treatments worst, etc., etc.
We have, yeah. So at least in the UK, the Office of National Statistics, they have developed this score that's called the Index of Multiple Deprivation, that they look at specific characteristics of the postcode. I think it's like crime and pollution and access to green space, and they have a score, and depending on that score, they just rank.
Okay.
And we can stratify the analyses by that and by ethnicity. But again, in EHR data, we know for a fact that certain high-risk populations are excluded. So homeless people, injecting drug users, sex workers, prisoners. So there's still a huge number of people that are not in the system. So you have to kind of you have to be aware of that.
Okay. Are there more questions? If there are no more questions, so thank you very much again.
Thank you.